All right. It feels terrible to break up the conversation. Sorry to do that to you. And thank you for accommodating that short break. But we will get into hosting our keynote presentation featuring Dr. Sandro Demaio from VicHealth. So Dr. Demaio is, of course, VicHealth's CEO, a medical doctor and a globally renowned public health expert and advocate. He trained at the Alfred Hospital in Melbourne. He holds a master's degree in public health, a PhD in non-communicable diseases, and has held fellowships at Harvard Medical School, Copenhagen School of Global Health, Johns Hopkins Bloomberg School of Public Health, and the University of Melbourne. Please welcome the highly accomplished Sandro Demaio.
Thank you. It's wonderful to be here. I think this is the first time I've ever been to a meeting that's running early, so I apologise that I was parking and kept everyone waiting. But I'd just like to start by acknowledging the traditional owners of the land that we're standing on here in beautiful Bendigo. What a stunning outlook it is to be reminded that these are the lands of the oldest continuous culture in the world, always were and always will be Aboriginal land. And I use every opportunity I can at the moment just to reaffirm my commitment, but also that of VicHealth, to reconciliation, to fairness, and of course to a pathway for treaty here in Victoria and maybe one day Australia. So I'm really pleased to be able to present for a little while this morning, and also really happy to take questions and have a bit of a conversation. I'm going to be talking a bit about our work and a bit about prevention more broadly. And I'll also take you through our brand new 10-year strategy. I also just want, of course, to thank the organisers. And, this region has always punched above its weight in terms of place-based approaches, the importance of, I think, community efforts for health and wellbeing, and, of course, the leadership of the council and Bendigo as a hub in many ways, not just as a front runner in health promotion statewide and nationally, but also the leadership that the local government and the region continue to show. So for those who don't know, VicHealth is a state's prevention agency. We were established in 1987 through the establishment of the Tobacco Act, and we were the first agency of its kind in the world. Overnight, the Victorian government decided to ban tobacco advertising. So you have to cast your minds back to the late 80s. You would jump on a plane to London and sit surrounded by cigarette smoke. You'd come home from a nightclub and your eyes would be burning and your hair would stink and you'd have to have a shower. The culture of smoking was so ingrained in the culture of society across Victoria and across Australia. And fundamentally, this commercial determinant, the government decided with an immense amount of courage and foresight to take on a very difficult and ingrained cultural element and commercial determinant, and that, of course, was big tobacco. It had decided to increase tobacco excise, and along with the increase in tobacco excise, ban the advertising of tobacco in our sports, arts and cultural activities. And so overnight, the chests of our VFL players, the sponsors of our ballet, the Formula One Grand Prix, the tennis, all of these really iconic Australian and Victorian events, organisations, parts of our culture, parts of our identity, importantly, moved a step away from this important and deadly industry, an industry whose products, if used exactly as intended, will ultimately kill 2 of their long-term users. So really, really important and ambitious, visionary decision by government. And I think it's important to start the talk with this because, first of all, we should be proud as Victorians. I clearly was not involved. I was just a few years old, and probably many in this room may not have even been born. But we are inheriting this incredible history of leadership in the state of Victoria. The VicHealth model of taking that 0.5% increase in tobacco excise, of buying out all the advertising to help to transition those organisations onto healthier sources of advertising and partnerships, and of hypothecating that tax, earmarking or ring-fencing that money, and government saying we're actually going to give the money to a small, scrappy, independent agency and give it the powers to speak truth to government and be really clear in its legislation that this organisation is going to work for the people of Victoria, not for the government of the day, I think was incredibly visionary and incredibly brave. And in the last almost 40 years, not only has VicHealth and its protected appropriation and its very clear legislation that reminds us every day who we work for, all of you, not only has that delivered incredible dividends for the health and wellbeing of Victorians, but it's also, in fact, cast an international shadow. There are more than 30 jurisdictions around the world that took the VicHealth model and made it their own. So Queensland Health and Wellbeing, Queensland Agency was established 4 years ago now on the VicHealth model, almost identical. Wellbeing SA is currently, they're establishing an agency in South Australia. Western Australia was about 4 years after us in 1991. But we've also helped to set up Tonga Health, Thai Health, Singapore Health Promotion Board and the Swiss Health Promotion Foundation. So again, the legacy of Victoria, not just in tackling the tough issues and putting populations before profit and taking on what we now know as the commercial determinants 40 years ago before it was even, in our kind of minds or our lexicon, but also, thinking really creatively about how we fund and support and govern these tough endeavours of unpacking and unpicking the structural drivers of poor health and inequality is something that Victoria has been a world leader in, is a world leader in, and we should be proud of that because you're all part of that. So prevention, ultimately, I started my life in medicine. I worked, I did some rotations here in Bendigo, but spent quite a bit of time in Mildura and sent a few patients to Bendigo. But I noticed really early on as a clinician that whether it was in Mildura, whether it was in Melbourne, or whether in fact it was in Sri Lanka after the Boxing Day tsunami in 2004, 2005, overwhelmingly the patients I was treating everywhere in the world, and particularly in poorer communities that faced significant structural barriers, they were dying from diseases that we knew how to prevent. This wasn't a technical problem. We had the tools, we had the know-how. It was simply that we were making the wrong decisions as a society, through policy, and what I realised was, prevention, that old adage of an ounce of prevention is worth a pound of cure. If we could find a way to climb to the top of the cliff, and instead of continuing to patch person after person who fell to their peril at the bottom in emergency departments and tertiary care, if we could better equip primary care, if we could work at the local government level, if we could work at the place-based level to build fences at the top of the cliff and stop people from falling in the first place, we would end up with a much more sustainable, respectful and ultimately effective healthcare system, but also society. And that, of course, is prevention. So if we look at the health challenges facing Australia, in some ways it's unique, but in many ways this is a challenge that faces the entire planet. So over the last, probably 200 years, Australia has experienced this incredible increase in life expectancy. Generation after generation, we've got taller, we've got healthier, and our lives have got longer. That's been the kind of mega trend for 150 years. But something started to happen late last century that took us a little bit off the rails. Part of it was because we made such great inroads in the traditional public health challenges of water and sanitation issues, so people had access to fresh water. We had, toilets. We had everyone got relatively well fed, and were able to vaccinate kids. And those things led to an incredible change in what we call the epidemiological transition, the shift from high infectious disease burden to the emergence of chronic disease. But at the same time, we saw this rapid emergence, this incredible change and increase in chronic disease and obesity. And this really happened over 30, 35 years. I was in Albury-Wodonga last week, and we were talking about type 2 diabetes. So when I was a doctor 15 years ago, type 2 diabetes, we called it adult onset diabetes. It didn't occur in kids. It was almost unheard of. And certainly I never saw type 2 diabetes in a 13-year-old or a 12-year-old. But this, in the last 15 years, has become common practice. Speaking to a colleague of mine who's a gastroenterologist, same story. Non-alcohol related fatty liver disease in teenagers. This was unheard of, like not even in our thought patterns 15 years ago in the healthcare system. So there's been this massive and incredibly concerning shift in the health of populations, such that we're seeing a dominance of chronic disease, multi-morbidity, so multiple chronic conditions. 1 in 2 Australians now live with chronic disease. Most will end up dying from those diseases. Largely, we know how to prevent them or significantly delay them. They're most effectively treated through primary prevention, or at least through primary care. They're best treated outside of hospitals. 80% of health determinants for Victorians are factors outside of the health system. And yet the dominance of chronic disease continues, and the average Australian now lives with 13 years of pain and suffering at the end of their life from this group of diseases we largely know how to prevent. So we've seen this incredible shift or transition just in a couple of decades, and what we're now seeing is, in addition to this dominance in chronic disease in the epidemiology of Australians, mostly driven by a group of what we call modifiable risk factors. So tobacco continues, but also poor health, alcohol, and physical inactivity. We also see that it's incredibly unfairly distributed. So regional Victorians, rural Victorians, much higher risk of poorer health and poorer health outcomes because of a range of barriers, structural barriers that regional Victorians and particularly remote Australians face. But we also see, poorer, the overwhelming dominance of chronic disease in poorer communities, in First Nations communities, and increasingly now in younger and younger people. So I'm going to, before I get you all, I can go on about this for hours, but we're going to try and get to the solutions because it's much more of a constructive conversation. But I will show you a short video that we put together. I apologise that it's me presenting a video of me. It's very kind of like meta. But it's a video that ABC put together, and it kind of explains everything that I'm talking about. But instead of me banging on about it for another 15 minutes, it's about 90 seconds. So I'll just watch this and then we'll keep going.
Heart disease is now the leading cause of death among Australians, followed closely by stroke, diabetes, cancer, and mental illness. And while it's easy to blame each other or point the finger at ourselves, it might also be the system that's making us sick. Don't believe me? Let me show you. Our postcode can predict how healthy we're likely to become. Access to healthcare services, education, employment, public transport, green space, and parks all influence the options we have when it comes to our health. Chronic health conditions are significantly higher in regional and rural areas than the national average. In lower income suburbs, there are 2.5 times more fast food chains than in richer ones. It's also hard for towns to fight back on junk food chains being built in their own community. Almost 40% of what we eat are ultra-processed foods. They have minimal nutritional value, but they're high in fat, salt and sugar and artificial flavours. Although many are marketed with confusing labels such as healthy, a recent US study has shown they're linked to higher rates of disease, such as diabetes, heart disease, and even early death. In supermarkets, unhealthy food is twice as likely to be on sale as healthy food, and junk foods are placed right at kids' eye height. Kids are vulnerable to online and real-life advertising. Regulation around what information is collected about our kids online on social media is incredibly weak. In fact, by the time a child is 13 years of age, An estimated 72 million data points have been collected on them. This profile can be sold to advertisers, making those pesky junk food ads more targeted and irresistible to kids. But there are countries and cities around the world that have taken a stand against the advertising of unhealthy food and drinks. In 2019, junk food advertising was banned across London's entire public transport system. Chile restricted unhealthy food marketing across media platforms, including online. So what about the rest of us? Could and should Australia do more? Whether it's the way we design our cities or the way we make and sell food, it doesn't have to be this way. So start talking about this with your family, your friends, your school, in your workplace, and with people in power. What could be more important than our health? So what are you waiting for? Let's fight for a healthier us. There's a lot you can do. In fact, you'd be nuts not to.
Excuse the terrible pun. My God. Anyway, so now I just want to talk about our brand new 10-year strategy, because that really kind of encapsulates a lot of the thinking that has underpinned where VicHealth is going and how we believe that we can create change together across the next decade. So we've just launched a brand new 10-year strategy. It seems like almost a bit of an anachronism to have a 10-year strategy when a world seems like a week seems like a month at the moment, and kind of a month we don't even remember what month it is. But when we're talking about trying to address the deep structural drivers of poor health and inequality across Victoria, we felt it was really important to set long-term aspirations and set, I suppose, long-term goals. We also heard from a lot of our partners, including here in Bendigo, that one of the challenges of working with us and also with government is that the sands kind of shift rapidly. And so having greater certainty, greater clarity and greater commitment from an agency like ours that, this is the space we're going to work on and really focus on. And we invite, our partners to work on these with us over a decade, means that you guys can invest in focusing on these issues with us, and that together, hopefully, we can make quite a significant difference over the coming 10 years. So we went through a very comprehensive sort of research and insights gathering phase. This included interviewing more than 200 of our partners across the state. It started with a supplement in the Medical Journal of Australia about 2 years ago now, with 65 of the country's experts looking at what is Australia's pathway to health for all by 2030, and that took a determinants view. So, for the last decade, the kind of dominating, since about, the early 2010s, the dominating frame through which many of us have seen prevention, health promotion and sort of barriers and opportunities to create better health has been through this lens of risk factors. So the idea of, the modifiable risk factors that individuals take, this kind of lifestyle disease, lifestyle behaviours narrative, which in some ways at the time seemed very helpful, but actually now looking back we realise had a whole lot of really unhelpful unintended consequences. Most importantly, it laid the blame and the focus back on the individual and really individualised the problem, that it was about people's behaviours, it was about things that they could change in their lives, it was about getting more exercise or putting less sugar in their mouths, which I'll get to in a second, but we realised absolutely is not true. I mean, it is true, but it's not true. The other, though, is that it was a very biomedical model. And again, we know that if you take your genetics aside, 80% of health outcomes for Victorians are determined by factors outside the healthcare system. And so actually, the last century, the major gains in life expectancy for Australia were not delivered by doctors. They were delivered by economists, by engineers, by people who were working on things like vaccinations, water and sanitation issues. And in the next century, it will be the same. In the next decade, many of the challenges and structural changes we need to achieve are not really under the control of health leaders and certainly not doctors like myself. So we need to move away from that biomedical model, and we need to make sure that we're not personalising, over-personalising the issue such that it ends up being a conversation of shame and blame. And so that really emerged strongly through the supplement in the MJA from 2 years ago, and I encourage you, it's openly accessible. It's the one on the right-hand side there. I'd encourage you to check it out. We also got a recut of various national frameworks and evidence, so that we could really understand where we should be investing for the next decade, but ultimately also the normative nature of our strategy. We realise that, you know, we're very proud that VicHealth tends to create a framework that others, if done well, can buy into and be part of. And so that's the multiplier of VicHealth's model, and certainly something we aspired for, which is again why we started by really listening deeply to our partners across the state. And so 4 key principles emerged through the new strategy, and these are quite different from, I think, how we've worked in the past, but also often how government works. So the first is it's a 10-year strategy. These are not problems that are solved easily, and they're not issues that are shifted quickly. So if we're talking about really doing the deep, difficult work around structural barriers to good health, it is going to take 10 years. The second is that we needed to take a systems approach. I'll talk about that in a lot more detail in a second. But ultimately, it's the insight that you don't change diets for people in Bendigo by pointing at them and saying, eat more vegetables. You know, it's unhelpful. Very often, it's not particularly respectful, and it doesn't work. And that's not to say that education isn't important. It absolutely is. And continuing to build people's agency is important. But if the only thing we do is focus on shifting, basically telling people to eat a healthy diet and ignoring the fact that it's not accessible, it's not affordable, and it's not aspirational, because from literally 6 months old, they've been advertised to by industries that connect cartoons initially with junk food, and then connect AFL performance with junk food. And then at Auskick on the weekend, they get a voucher for, you guessed it, junk food if they do well. If they've been so socialised from literally 6 months of age, when they're not even able to talk, but yet we know kids can start to understand and interpret and connect advertising with brands and behaviours, then telling them to eat better food when they're in their 20s, 30s and 40s, despite them wanting to be the best parents in the world. There is not a parent in Victoria who doesn't want the best for themselves and their families, ignoring the fact that their aspirations have been shaped and outsourced to the processed food industry for the previous 30 years is a nonsense and isn't going to get us to where we need to go. And as I said, very often isn't the most respectful way to approach the conversation. And I know you all know this, but these are things that sometimes can be hard to hear and can even be new insights. The third was really embedding equity, so understanding what equity... equity is easy to say but hard to do. What do we mean? Going to that next layer of unpacking equity, how does it show up in our work? How do we hold ourselves accountable as an organisation? And how do we live it, even within the organisation, through the diversity of our workforce and our lived experience as an agency? And the fourth, I think, is almost the most important, and that's the kind of layered approach. So, it's when I have conversations with politicians, it's the lived experience examples that I get from spending a day working alongside community leaders here in Bendigo, or last week in Wodonga meeting the food share leaders and understanding the real issues facing people in the north of Victoria, the types of Victorians that are facing food insecurity for the first time, what that looks like and feels like. Those are the conversations that then we are able to use and work with to shift the mindsets of politicians to get better policies across the line. And of course, it's the policies that will then reinforce and support the great work that's happening at the place-based level. They're not mutually exclusive and they're not competitive. Actually, they're hugely complementary. And so whether it's our global partnership with WHO and UNICEF supporting and informing global best practice, but also learning from other countries so that we're not wasting time duplicating efforts and making the same mistakes here in Victoria, whether it's the federal policy work that we do in alcohol, harm reduction, or indeed at the moment in e-cigarette legislation that we've been able to be part of, moving that, really shifting that forward and putting Australia back at the forefront of global tobacco control. Whether it's a state legislation that then reinforces some of those actions. In e-cigarettes, for example, enforcement will happen at the state level. You can't ignore that, and you need both levers. But the lived experience of the e-cigarette challenge, the fact that it's the #1 behavioural issue in schools now, the fact that it's starting fires in landfills, and street bins. These are issues that are felt by local governments and by local communities. And it's the 13-year-old calling the tobacco cessation line 8 months ago in tears because he didn't want to disappoint his parents, but he was one of the only kids left in his class who weren't addicted to e-cigarettes. It was that story that Mark Butler, still tells today that we were able to relay from the fact that we fund and support Victoria's tobacco line. So it's that layered approach, and actually all of them reinforce one another. And I think it's really important because there are not many organisations that are able to do that work, but we rely then on local partners like yourselves. So our systems approach is really one that sees us sort of thinking about systems in three dimensions. So the first is that we as an organisation, much like many of you, the more that we're able to work together, if we're trying to improve the diets of kids, it is going to take certain state and federal policy levers, working with our food systems teams, working with our social marketing campaigns teams, working with our research teams. So within VicHealth, we commit, and this has been a hallmark of the local government partnership. It was Mildura who told me Mildura City Council a few weeks into the job, that as we were redesigning the local government partnership at VicHealth, they wanted to see a world where they didn't have 25 contracts with all the organisations that we work with and fund taking up most of their bandwidth, which meant that they had less time to actually do the good work that we wanted them to do. So by us understanding that and kind of getting our house in order a bit, by us working as an integrated system that's better connected and more coordinated, we get better outcomes for Victorians. And I think that's the same in most organisations. The second is the ecosystem that is health promotion. So, very often there's duplication, there are misunderstandings, but there are also just so many opportunities for the organisations across health promotion in Victoria to work more closely together. And the third is that insight around, shifting the structural barriers around individuals, understanding that it's not just, individuals making poor choices that results in chronic disease. It's this incredibly curated and fairly unfair dynamic system that we need to reshape. We have 3 aspirations for Victoria. So health, as it should be, contributing to SDG 3.4. We've all committed to that, our state and federal governments included, and that's about healthier, longer lives for Victorians. Makes sense, we're a health agency. The second, though, is really important, particularly as we go into the next couple of years. But in general, people sometimes thank us at VicHealth for supporting their work or for providing a grant. And my answer is always, at the end of the day, you don't have to thank us. It's your money. Our job is to get the best possible value out of the money you've entrusted with us. But at the end of the day, it's taxpayer dollars. So, that return on investment and making sure that we're returning really strong value and articulating that we're able to measure it and we're able to communicate it so that people don't misunderstand, prevention as a cost rather than an investment. And the third is, of course, equity or fairness and making sure that we're starting to reduce the inequalities that exist. We've also re-articulated our role. So our role in the 80s and 90s was about empowering individuals. It was about building people's control over their health. Agency is absolutely critical, and people do have a very important role in determining their health. But we've slightly re-articulated our role. We see our role as really reshaping the systems that enable them to enjoy good health. I always say the difference between a choice and an option, if you don't have the option, then we can't talk about a choice. So if good food is not affordable or accessible, then it's not people making poor choices. It's people not having an option. these are three systems that we've called out. So it's the last four, as I said, the last 10 years, our sort of health promotion space has been dominated by this 4x4 model. We're getting very nerdy for a second, but it's the 4x4, so it's 4 modifiable risk factors, 4 disease outcomes. Many of you will have heard that. What we've designed here is what we call the 3x3. So it's 3 long-term aspirations: health, equity, economy. It's 3 systems that we're going to reshape: neighbourhood and built systems, commercial and economic systems, and food systems. And then there are 3 cross-cutting equity lenses that I'll touch on in a second. So in terms of neighbourhood and built systems, this might see us, for example, instead of only running physical activity campaigns, or instead of only focusing on education around healthy food, we are starting to look very seriously at the issue of planning laws here in Victoria. So we know that on any given week, I probably get an email from at least one regional Victorian community who find themselves at VCAT spending a lot of public money, a lot of time and effort, trying to keep a multinational fast food or alcohol company from building a massive new outlet in their town. In general, they end up spending a lot of public money, they end up demoralised, and they end up losing, and then living with this reminder every day of the fact that they couldn't even keep, despite all their best efforts, they couldn't even keep the Golden Arches out of their small country town, or the second one, or the third one. And that's because in Victoria there are tighter rules around how close you can build a pharmacy to another pharmacy than a McDonald's to another McDonald's. And until the planning laws change, we can tell kids don't eat McDonald's, or we can try and promote healthy food. But if the availability of good food is limited because they're undercut by the prices of fast food, and if communities literally can't keep these fast food companies out, then we're going to continue to play whack-a-mole. This is our local government partnership. I'll keep moving because I think you know quite a bit about that already. The second is commercial and economic systems. So our foundations are in tobacco control. We've been working on the commercial determinants for almost 40 years. We've just not talked about them in that way. And what we realise, though, as time has gone along, and interestingly on the drive up here with EJ and Bonnie, we're talking about this, is that the products might change, but the practices stay the same. So what do I mean by that? Well, anyone who was around 30 years ago when Nigel Grey was leading the efforts on tobacco control in Australia would think that it's Groundhog Day in 2023. The idea that the same industry has found a new way of delivering the same chemical that's highly addictive, that changes the structure of the brain, that influences and affects the long-term health and well-being of young people, and that we're kind of slowly but very clearly walking into a kind of nightmare 2.0 of having thousands and thousands of young people addicted to nicotine, a new generation addicted to nicotine, which early evidence suggests they're then 3 times more likely even to go on and smoke cigarettes, the original product. The idea that we're kind of back with the same industry, with the same practices, selling just a slightly different product, tells us that something clearly has to change. Otherwise, we will continue in this cycle. And the power imbalance between communities and these companies is immense. So it's about saying, well, what are the upstream drivers that enable those companies to work in that way? We've talked about the planning laws, but what are the others? There's a big conversation nationally happening at the moment around data privacy. 72 million data points will be collected on the average 13-year-old child by the time they hit teenagehood. That data is used and weaponised against that individual child so that an industry willing to pay is able to put the right product in front of their eyeballs at the exact right moment to get the effect that they want. And it's likely going to be the moment, where they're tired, lonely, vulnerable, feeling down. They know their postcode, they know their feelings, they know their friends, they know what they like, they know what they don't like. They know more about your kids than you do, let's be honest. And we allow that data to be harvested, collected, curated and weaponised and sold off to whoever's willing to pay to put that product in front of the child's eyes. Now, there are countries around the world that don't do this. It's not rocket science, and it's not some kind of, leftist dream, parallel universe. There are multiple countries that say kids are off limits. The only people who should be shaping the preferences of kids are their parents and their friends and their communities. And so they're off limits from all advertising. So, we have a long way we can go that would actually mean that it doesn't matter what product comes along to the market, the practices are simply not allowed. And that's more of the space that we want to focus on. Again, limited funding, big challenges. We need to be investing where we can have the most impact. We will still continue to support, of course, the Quit Line, a range of services. We're heavily engaged in anti-vaping education that will roll out across all schools next year. So that still remains a really important part of the puzzle. But how do we sort of try and get ahead of it a little bit more? I'll keep going. This is a video. You can watch it. It's Quit. I'm conscious I'm probably now we're running behind. It was good that you're ahead of time. And the last won't be any major surprise, but it's food systems. Food is the number one risk factor for disease worldwide. It's number 2 here in Australia, but very, very much approaching tobacco. It has enormous influences on our healthcare, on our health, and on our health systems, and it also has enormous opportunities. It's something we're very passionate about. Your region is well known for. It's a very positive conversation, and it's a much more holistic conversation than nutrients or talking about individual parts of food, which we've realised actually is not that helpful and is not terribly effective. What we need to do is really rethink and reshape the way we govern and structure our food systems. So we have got a program across 7 communities, including here, and the incredible team at Your Food Share, where we've built food hubs over the last 3 years that are owned by young people, run by the community, and it really was based on the insight that we had a food relief system that wasn't best set up to be able to support young people. We're seeing record numbers of young people facing food insecurity. We know the stats that we're seeing around the impacts of the current economic crisis and cost of living crisis and the generational divide. This is going to become a bigger issue. And so how do we reshape the way our food hubs and our food systems work so that, in best case, long term, young people are not food insecure, but also in the short term that we've got a food relief system that is able to respond to young people, the changing demographic that is faced with food insecurity, that provides pathways into the food system and food systems advocacy, but is also responsive, healthy, respectful and culturally appropriate. That's one of the teams. That's where we've got our food hubs. So I talked before about the 3x3, 3 aspirations, 3 systems, and then we've got our 3 lenses. And this is sort of how we see the world. So it's not what we do, but it's how we do the work. And the first is, of course, climate change. So it's here, it's real, it's happening. It's the biggest health challenge to face Australia this century, and there are enormous opportunities for co-benefits in the work that all of you do. So VicHealth is not going to become a climate change organisation overnight, or probably at all, but we are going to commit to doing 3 things. So the first is, being very clear that climate change is a health issue. And we'll be very vocal on that and supporting organisations that are leading in that space. The second is that we want to do our part. The health sector is incredibly carbon intensive, so looking not just at direct emissions but Scope 3 emissions. But I think the most important part of the puzzle for us in prevention is that, if you were to look at a carbon less intensive, let's say an environmentally friendly diet, it is basically the modified Mediterranean diet. It's basically the diet that we would recommend people for best health. So the co-benefits for climate from shifting populations to healthier diets through systems change are enormous, absolutely enormous. The same can be said for the way we design our cities. If our neighbourhood and built systems are built with health front and centre, the environmental co-benefits are enormous. Not just carbon emissions, but also, even things like air pollution. The second is a commitment to being community-led and informed. So, our job is not to come into Bendigo, and talk about, and tell everyone what to do. We will never do that. If we do that, you've got my mobile, you can call me. We want to hear about it. So our job really is to support great people getting things done. And that is the kind of systems approach. So, the place-based model across local governments, it's about really deeply respecting those relationships. It's about mapping out that local system. Yes, there are some empirical skills like co-design or working with young people or systems leadership. Yes, we'll bring the global best evidence of what the literature says works in other places that might be helpful. And yes, we'll connect you to other councils who are on a similar journey and maybe give you some money to get things started. But we're not going to come here and tell you what to do. You guys know your communities better than we do. You know the solutions better than we could ever know. But there's a role that we can play, and we'll commit to playing that in a way that is respectful. And the third equity lens is around the intergenerational nature of these challenges. So, yes, we are responding to a challenge today, but even if we just think about the evolution in chronic disease that I talked about before, that 15 years ago, issues that we didn't see in people under 30 are now affecting teenagers, we have to take that longer term approach, and we have to be thinking about health across generations. So this is how it all comes together, 3 systems, 3 lenses, and I'll finish by just saying, for those of you who are kind of still thinking, not so sure about the systems approach, I mean, we're on a journey. So, we absolutely think this is the way we should be working, and certainly for a relatively small agency that works through partnership in everything we do, this is how we have to work to get things done. But you can see here that the risk factors approach, they're not disappearing. It's about embedding them through that systems lens. And then across those different equity lenses. Finally, if you are in Melbourne, a small shout out. We opened our. This is beautiful. So maybe you don't ever want to come to Melbourne ever again. And you've got great food. The Saigon, the Japanese place just down the road, Harpoon Social. My God, what great food. Anyway, I digress. So if you are ever in Melbourne and you'd like somewhere to work, we have a co-working space that's free and open. We opened it about 18 months ago. We have 110 partners who regularly use our space. We've got meeting rooms, end-of-trip facilities. We're about a short walk from Southern Cross Station, and that was by design on purpose so that our regional partners could spend more time in our space. So we'd love to continue the conversation. We'd love to see you there at the Victorian Health Promotion Hub. And I'm happy to take some questions if we've got time.
Thanks very much. I apologise for missing the first few minutes of your talk.
That's right.
I just had a question about evaluation. First of all, if things don't change, where are we headed? So I know that's difficult to predict, but I'd like your views on that. But also, how are you going to measure the success of this approach?
Yeah.
I mean, I'm not being critical.
No.
I'm just interested.
And my staff are all smiling because we're still working it out. So we're kind of very often data rich but insight poor. And the other part, and this is not a kind of an escape, but I do also believe that a lot of public health very often is about making the best decisions you can on incomplete information. So we have a business system that we've built over the last couple of years. It's a Salesforce system that provides a huge amount of data back from our partners, a huge amount of information also from all of the interactions we have with partners. So it's qualitative as well as quantitative. You have the Victorian Agency for Health Information. You have all the data that's sitting in local governments. We have partnerships with local public health units now, so data out of health services for the first time. So the access to data is not so much the problem, it's making sense of it. And the approach that we're taking, so out of the 10-year strategy, we've now just finished building with our teams, very much led by our managers and executives, what we're calling a 4-year action plan. So it's sort of a sub-strategy, if you will. That includes very clear outcomes that we want to see under each of those systems. So each of those 3 systems have 3 long-term outcomes, and then each of those have actions that we commit to doing, and there's about 50 of those over the next 4 years across about 10 teams and then all of our partners. And that will allow us to track much more closely, not just those 3 aspirations, so health, tracking a metric like diabetes prevalence. Obviously, takes a long time to see health outcomes from systems change. Diabetes tends to be a little bit more sensitive than things like cardiovascular disease because it's a kind of intermediary in some ways. Also, we've got good data through partners like Diabetes Victoria. So we're looking at how do we track the health outcomes at the aspiration level across the 10 years. The return on investment, we're building stronger partnerships at the moment with some of the health economics teams at Monash and Deakin, because there is actually good capability there, but we haven't typically been very well connected. So sharpening the tools of how we measure economic return and wider economic value, if you will, from the work that we're doing so that we're able to measure that. And then the equity aspiration is actually an internal budgeting commitment that we've made. So that's relatively easy to measure. So the 3 long-term aspirations will be measured largely through strengthening partnerships and using partner data. And then the wider kind of systems change, the process has been to take the 10-year strategy, develop a 4-year action plan with 9 outcomes. From those 9 outcomes, we've developed actions that we commit to achieving that are very tangible. We can say we've either done it or not, and then we will track those through the wealth of data that we actually have, but we just need to kind of make better sense of. So that was a very long-winded way of saying we're still working on it.
Any other questions?
Thank you. Dave Richardson's here. Give us a wave, Dave. Chair of the Regional Partnership. And one of the things that they first identified was one of the things you said in your slides. Chronic disease prevalence is higher in regional areas and lower life expectancy in regional areas. And that's kind of part of the birth story of Healthy Loddon Campaspe. So my question is, do you know of anywhere in the world where that's flipped?
So, yes. So there are kind of very small examples. So there is some evidence out of, for example, Amsterdam that they've managed to bend the curve on child obesity. I think the data's still, working out whether they've truly done it or not. There have been place-based projects in Northern Europe that have also done some interesting work around cardiovascular disease. Some of those are 30, 40 years old. I also always I spent 3 years of my life living in Denmark, and actually back and forth between Denmark and Mongolia. And so you had one country that was kind of an economy that was rapidly emerging, the fastest growing economy in the world, and another one that has a world-class health system. Denmark, interestingly, at the moment, is closing hospitals. They've got too many hospitals. And they also have an obesity rate half of Australia, but a GDP pretty much the same, and genetics pretty much the same. And they've got quite rural areas as well, because they're obviously a constellation of islands, so slightly different challenges. But yeah, access and rurality and socio-demographics, some similar structural barriers. So there are definitely, it is possible. And then you've got examples like, countries in Latin America who have implemented, like Chile, who've implemented warning labels on foods, banning advertising to kids, and a sugar tax, and they've seen very dramatic changes in consumption. They've seen consumption change with a really progressive element, so poorer communities are benefiting most. Some countries have been able to then hypothecate the revenue created through things like fiscal policies or sugar taxes to support like free dental or childcare or opportunities, particularly for kids from poorer neighbourhoods, or even just give them access to fresh water that they can actually drink. So you get that kind of double dividend. So definitely there are examples where it's been done. Anyone who tells you it's too hard or, no one's managed it, that's absolutely not true. And usually the industry's in their ear. But it's difficult, and no one's done it well because we still live in, we are still living in a kind of globalised food system that is completely commodified. And that's hard to escape from. So you're not going to ever get rid of kind of all of the influence. And in fact, some of the global targets that were set even at the UN level were simply plateauing, so like not getting worse. And that would be a good start. Yeah.
Thank you. Just a question around that. You talked about the economics and the data that you're getting or have got access to. We've got some people locally who are doing some really good things economically with growth, and jobs and all those sorts of things. And then we've got obviously things like Healthy Loddon Campaspe who are doing great work with public health. But sometimes we're at a local level, we struggle to see each other's perspectives and build that relationship. We know it's important. They may know it's important. I'm not sure. But do you have any advice on how we can? I'm not sort of talking about big companies, but more like our local government teams or other economic partners locally.
Yeah. No, it's a really important question, and I'll tell you a story before I answer the question. It's a common theme of today, you probably noticed. Anyone who's desperate for me to stop talking and go home, I'm really sorry. So I remember once I was working at WHO, and I was running a scientific series on trying to find the commonalities between obesity and hunger, and the fact that they're actually common intervention opportunities to address both, because countries like Indonesia, they have 30% stunting, so long-term hunger in kids, and 30% obesity and anemia in adult women. So hugely complex for countries to try and address, and it's not just about producing more food anymore. And when I spoke to the community that were focused on chronic disease and obesity, they were like, yeah, but Sandro, obesity is so difficult and hunger's so simple. And then I spoke to the hunger community, and guess what they told me? Yeah, but hunger's so hard and obesity's so simple. So they were both saying basically there was this opportunity. Well, I could see these incredible common opportunities, but they didn't see the links, and also there's kind of this I suppose a lack of like understanding and respect possibly as well. So it's a great question. It's a really important question, because what you're talking about are co-benefits. And one approach could be, bringing an external partner in to, bring a group of people together. And we're always happy to play that role. But the other approach could be to use kind of methodologies. So the systems mapping process that we work with you guys on at the council level that underpins our local government partnership, it usually ends up resulting in kind of finding the same outcomes, but what it allows you to do is to sit down with different actors and map out the same system and realise that actually you're all in the same system that ultimately results in poor health. But by addressing job insecurity, you're addressing food insecurity, and you're addressing probably domestic violence, and you're having a huge impact on the stress on the healthcare system and on the budget of the hospital. And so it actually allows you to start to, have the conversation, because they can see it physically mapped in front of them, and they can start to connect those dots. And that's what we did with the obesity and hunger communities. Was when we actually started to map it out together, we realised that things like early food systems, that breastfeeding and actually being able to afford to breastfeed, for example, or healthy diets would deliver at a country policy level, would deliver really effectively for a country like Indonesia on both challenges. And we called those double duty actions in the papers. It's about co-benefits, and using methodologies can be really helpful, because it sort of allows everyone to start where they want to, but what you find is that actually we're all working on the same issues, just calling it something different. Yeah.
Hi, so I'm just interested in your thoughts around the blue zones. So the areas across the world where communities are living to 100 and beyond, and they're living very naturally. And they're some of the poorest communities in the world. And I think, when we talk about equity and equity of health, and you often hear the saying, health is for the wealthy, that kind of flips all of that on its head. And in terms of sort of trying to adopt similar models in Australia, that we could take communities and offer them the blue zone opportunity. What are your thoughts about that?
Yeah, it's interesting. When you look at... So when you look at the blue zones, very often they're either geographically or culturally isolated. And what I mean by that is that you look at... So, for example, Italy now has a child obesity problem, a very big one. But they're about 20 years behind a lot of the very westernised Europe, and particularly the westernised Europe where they don't have a strong food culture. And so the common element is actually... not the geographic isolation or the fact that, Italian food culture is strong, or that Italians speak Italian and not English, and they're actually pretty terrible. I will say this as an Italian. The uptake of English is was slower than a lot of other countries, but it actually protected them. We think that the reason the child obesity was lower in Italy and also places like Japan, where they, again, really strong food culture, a little bit isolated in terms of language, in that they're not an Anglophone country. It basically just took the industry longer to get there and get their hands on their kids, if I put it really crudely. So for me, the takeaway is not that all Victorian... giving people access and being able to afford and enjoy food, through programs like Stephanie Alexander's program or Food Share, or all the different solutions that we're going to need to make it possible for more Victorians to enjoy, a diet more similar to what my grandparents, my nonna ate, 80 years ago, living in poverty, not being able to speak English, and arriving in this country as economic migrants. When you look at those diets, they are fundamentally very healthy. Their lifestyles were quite different from a manual labour perspective, and there was a really strong sense of community and social connection. So, it does go back to those risk factors of physical activity, healthy eating, and social connection. But actually, the hypothesis of why Italy took longer to end up with a child obesity epidemic is because also it took longer for industry to permeate their society, because they had a strong food culture, because they spoke Italian, not English, and there were some government decisions as well. So I think it goes back to, I think we could almost learn the wrong lesson from blue zones, but the lesson I take is that actually we're working on the right things, that we need to try and give kids the opportunity to develop their own food preferences, to really celebrate their food culture, to use food as a positive, empowering tool to connect with others, and do that in an environment that's free from the influence of industries selling products that we know are associated with poor health. And that's the physical space as well as the digital space. But yeah, it's a great documentary too. If you haven't seen it on Netflix, yeah.
I was interested when you were talking about advocating to adapt the plating scheme so that fast food chains can't enter. Is there also talk about adapting or putting in regulation to restrict access to what is already there? So I was lucky enough to go to London earlier in the year with my 2 teenage sons. So I was made very aware of the stark differences between access to sugar. So over there they have regulations where the shelf space is much shorter. And it's tucked. You have to dig around in the supermarket to find where the chocolate is. You cannot get a massive family block of chocolate like you can here. And the cereals, they did not taste the same at all. There's a lot less sugar. And anecdotally, just talking to friends there's obesity has reduced drastically for kids as a result of just very small changes that is every supermarket. So that's quite a big impact?
Yeah, and the English model has been quite interesting because part of it has been industry-led, so it's been self-regulation, which generally doesn't work, but in the context of government, like standing there with a really big stick, sometimes companies suddenly find the altruism to do something. But there's also been government action, so they've banned advertising of junk food on public transport, for example. They saw a revenue increase, interestingly, for commercial players. So the whole kind of jumping up and down saying we're all going to go bankrupt turns out is not true from Coca-Cola. The other thing is also that they introduced a really clever approach to sugar taxes, such that it's focused on reformulation and not actual behaviour change. So again, kind of moving away from saying we need to tell people to stop eating chocolate to how can we shift the system to make chocolate less accessible, look at things like portion size, look at things like placing in supermarkets. But in that environment, it wasn't palatable politically to put a Mexico-style, dollar per pound or dollar per kilo or dollar per litre tax, which would in this environment in Australia be inflationary, and I don't think is really possible for Australia at the moment, if I'm honest. What they did instead was put a tax on the sugar content in the product with a threshold, so that companies like Coca-Cola, there was enough of an incentive to start reducing sugar, but not such a large cost that anything showed up at the checkout. Does that make sense? And then over time, so they say if the sugary drinks are over X percentage sugar, you have an additional tax, but the tax is quite small. So the tax ends up on Coca-Cola's bottom line, but it's not enough that it ends up on the checkout and people notice. So what Coca-Cola does, of course, is suddenly they find some way, which they've always said they can't do, to reduce the sugar content. And so they reduce it down below that threshold so that they no longer have to pay that additional tax. So what does government then do? Government then lowers the threshold. Exactly. And consumers don't see it, and it's not inflationary. So there are different options that it's not like this kind of there are different options that we could use in Australia, even in the fiscal policy space. And you're right, it's not to really, shift behaviours in communities. We're going to have to look at those different issues like product placement in supermarkets, promotions. So, as I said in the video, like far more likely to see junk food promoted for a whole range of different reasons. In some countries, that's not allowed. We know that placement at the end of aisles increases sales significantly. I mean, go to your local supermarket any day and look at what's on the end of the aisle and tell me that anything there is either environmentally or healthy, environmentally sustainable or healthy. It's all things that are, that we generally want to be consuming less of, but they're hugely profitable, and so they can afford to be buying, because they have to pay extra money to be there, buying that real estate in the supermarket. Yeah, but you're right. Other countries are doing it. Again, Australia is kind of being left behind in a way, and you go overseas and you realise whether it's Latin America, Northern Europe, the UK, even parts of the US, they're just moving ahead with a lot of these things.
If it's can exist in similar economies to ours.
Well, I think it's understanding the political economy of food. So why was Mexico able to get it over the line? There is actually a really interesting published paper exactly asking that question. Why was Mexico able to get a sugar tax? And it's the combination of a really organised civil society sector that is not all screaming different things and calling each other idiots, which unfortunately sometimes still happens. So everyone being on the same page from the civil society, asking government for one thing, not 10. It was about building the public support. So Bloomberg Philanthropies supported a campaign that built public support, that dispelled some of the myths like, it's going to be regressive, it's going to it's a tax on the poor, all of these things that we've certainly seen happen here in Australia and been quite successful, unfortunately, in stopping policy. It's, you know, and then it was about really making sure that when you do have a politician that wants to act, and there are only a few things that influence what politicians want to do, and you can ask Marie what those are, but you know, you can work them out. I mean, you know, politicians who have young kids who I talk to are really worried about this because their lived experience aligns with our concerns. So when you've got a politician who wants to do something, then really making sure that the evaluation, coming back to your question, making sure that the evaluation is strong, because the industry will absolutely fight tooth and nail to stop it, and they will fight tooth and nail in the first year to try and repeal it. And not just because they don't want Mexico to have a sugar tax, but because if Mexico does it, all of the other countries in Latin America will think, you know, particularly poorer countries who don't have as much money to fight these industries in the World Trade Organisations and other sorts of forums. It's like Australia with plain packaging. You know, the reason that that this conversation in Australia about e-cigarettes is going to get really nasty in the next couple of months, and has already, is because not because they're really worried about our market of 23 million Australians. It's because Philip Morris International, British American Tobacco, Japanese Tobacco, those companies, they know that what we do will create a pathway for lots of other countries in the Pacific, in Southeast Asia, much bigger markets. And that's why they focus on countries like New Zealand and Australia that are relatively small, but influential from a normative perspective for other policy environments. So when you've got a politician that's willing to do something, make sure that you've got a galvanised community, you've got a public that are ready and informed as best as you can, and that you evaluate it. And that's what the Danish fat tax was repealed after 12 months, not because it didn't work, but because they didn't measure it properly. They didn't ask the right questions. And so in 12 months, they didn't see a change in public health, and so therefore it was too easy for government and the opposition, I think it was actually change of government, with heavy lobbying from the dairy industry to repeal it. And, you know, that's a lesson that we've got to take heed from.
Thank you. I might close out the session with one final question. So Healthy Loddon Campaspe presents a huge opportunity for our region to create positive change. We've got, you know, state investment, 6 local governments working together, multiple partners on board. We're, you know, taking a systems approach. We have a new food systems framework for our region that we're scaling up with the public health unit to more LGAs. Yeah. Equity underpins all our work, and the things we do on the ground are place-based. What would be your call to action or one piece of advice to us?
Well, I mean, yeah, I mean, well, so Claire can answer that question in a moment. I mean, first of all, I do really want to acknowledge the work that you're doing and say that our strategy has been informed by the work of of this region, and it is a standout place-based example that I think we've learnt from, other parts of Victoria have learnt from. We often reference you guys on a range of different issues, including your food systems work. So, I think we have been able to build this strategy because of the great work of this region, and we just look forward to working more closely with you. So I suppose my call to action is, continue to work with us and inform our work and help us to inform the work of other communities across the state. And we've been able to really build a strong relationship over the last 4 years at least, but we're more committed than ever over the next 10. So let's work out what that looks like. And Claire is here today. She's leading our place-based investments. We're going through the process at the moment of really thinking about what the next iteration of those place-based investments look like. And the constellation of actors that you've talked about is so powerful. Local governments, local public health units, and then regional place-based initiatives. Overlaying that with VicHealth in a way that's respectful and catalytic, is just really exciting. So we look forward to it.
We're very interested to talk about that cost effectiveness. We've got a quote out at the moment to do a cost effectiveness evaluation plan.
Oh, great.
So it would be interesting to chat to you about your approach. And
Yeah, that would be fantastic.
thank you.
I think that brings us to the end of Sandro's presentation.
Great.
So thank you so much. We're thrilled to hear that the work that we're doing in this region has such an impact, and that that it's, you're noticing it, and that it goes into your thinking as well. So I think that's very reassuring for the team. It's a lovely message for you guys to hear today, and of course, keep going, keep doing your wonderful work. We're at 11 o'clock now. We're going to have a little break. We're going to have some morning tea. You can get back to that great conversation that you were having earlier. If you could just come back into the room a bit before 11:30, we'll call you back just to let you know the next steps. So yeah, we'll keep going together today. Thank you so much, and thank you, Sandro, again.